it can be eased for the juniors. We look forward to a great lecture now. Welcome, JP.
Yeah.
Please, you can start.
Yeah, good morning, everyone. We all know that foreign body removal, when it is accomplished with facility and safety to the child, so it's always highly rewarding. And this is one of the most, this is the only subject foreign body where no other specialty can deal with. Suppose if there is a thyroid, somebody else may do. Suppose if there is some lump in the neck or something, somebody may do in the oral cavity. But this subject is the only one where we can give life to the patient. So this is always challenging because we are dealing always a patient who is in the respiratory difficulty and anxious patients, parents. So we have to know the implications, problems that we come across when we deal such patients, especially in private practice. So now pediatric bronchoscopy is, we all know that the so before I actually go into my lecture, I would like to remember my teachers who have really taught me what is the ABCDs of ENT. And these are six teachers that I had in my life who are instrumental, who taught me ABCDs of ENT, these three during my postgraduate days. And once I completed, I learned a lot of things from these three people. You all know who they are. I don't want to name them again. They are stalwarts in their field. So now we know that one of the major accidental cause of the death in children is a pediatric airway foreign bodies. And we must also know that the most of the patients that we deal with are below the age of 3 years. To be exactly, it is the 18 months below is the critical and most commonly seen. And again, the male predominance is there over the females when they actually present to us. And once we say that there is a bronchoscopy is done, we must know that there are two types of bronchoscopies that we have. Number one is the fiber optic bronchoscopy, and number two is the rigid bronchoscopy. And fiber optic bronchoscopy is limited to the diagnostics, to know what diagnosis the patient may have, like a chronic cough or to take a biopsy. And rigid bronchoscopy is the one which is commonly used to remove the foreign bodies. There are places where foreign bodies are dealt with by fiber optic bronchoscopy also, but it has a limited role because the working channel, what is there in the fiber optic bronchoscopy, cannot hold the foreign bodies most of the times. And it is a rigid bronchoscopy that we mean when we say bronchoscopy and foreign body removal. See this news when it comes to in a local paper, like a child who had a foreign body in the throat, probably in the airway, has died before they reach the hospital. Or when they reach the hospital, it is not properly dealt with in a place where the ENT surgeon is not there. Or if the ENT surgeon is there, just for the fear of handling such cases, the child, most of the times, we listen or see this news in the local paper and we feel disheartened as to that a child died with a foreign body in an airway, that too with so many ENT surgeons around. So this should not be done, and no child should die with a foreign body in the airway when so many ENT surgeons are there. We must know the basics of handling such children and save so many lives. And when we go to the history of foreign body removal in the bronchus, it is the Killian who actually first did bronchoscopy, and then later on Chevalier Jackson, we know, who has really invented a lot of design instruments and spent his whole life in actually explaining the procedures of bronchoscopy in a pediatric age group, and he is now called as the father of modern bronchoscopy, or American. Yeah, he is the father of American bronchoesophageology, who has actually written a complete monogram on bronchoesophageology. Even though it was written some years back, still it is one of the most read book, and it is the Bible who has to really practice the bronchoesophageology. One must read this book, and he was actually nominated for the Nobel Prize, and he could not get it in 1930. and he has written this book. I think many libraries will have this old book, even though it is old, but still I can tell you this is gold. One must read all the techniques what he has mentioned in the book. May I ask the organizers to actually unmute everyone, please? There is a lot of disturbance in the. Yeah, so when we say that there is a foreign body bronchus is there, we are all, most of the times we are feared because of these four reasons. Because we are dealing with a small child with a narrow airway, and because of narrow airway, it is always difficult to actually do instrumentation. And if you do repeated procedure bronchoscopy, it is always risky, as the child may develop subglottic edema. So that is the reason, and we sometimes, most of the time, share the airway with the anesthetist. So because of these four reasons, that I can tell you that bronchoscopy is feared among us, that some complication may occur. We all know that foreign bodies are common in pediatric airway because of these reasons, that the child lack molar tooth. Because of that, there is poor mastication, especially nuts, and then they want to explore the world by putting the things in the mouth, and they always play with the things with the keeping in the mouth. And then because of all, plus the most important issue is this, the immature three-tier protective mechanism of laryngeal reflexes. God has given us a very good powerful larynx. Whenever something enters, the larynx will have a very severe cough with which the foreign bodies will be thrown out of the larynx. And the God has given the first protective mechanism, periepiglottic fold. The next one is the false guard, and then the next one is a true guard. So this is called as three-tier protective system of the larynx, which is actually not very well developed or not very well coordinated in the pediatric airway. And that is the reason the child will have foreign body in the more common than in the adults. So when do we suspect that the child may have a foreign body? There are two scenarios. Number one is when the child presents with a history of choking episode while eating, that is positive history of choking, followed by cough, wheeze, and decreased breath sounds. This leaves no doubt that the child has a foreign body in the pediatric airway. Just the most important thing is the witnessed choking. Number two, there is no history of choking, but the child has persistent respiratory symptoms like cough, breathlessness, and these children are moving from one pediatrician to another with a history of asthma or being treated as pneumonia or tuberculosis. So in these patients, there is no history of choking witnessed. So these kind of patients poses problems to the clinicians as to whether to do a bronchoscopy or to wait and see. So this kind of scenario, the two scenarios meet. So whenever any patient who gets treated with history, persistent cough, breathlessness, in spite of medical treatment, they are not getting all right. So we need to suspect that the child may have a foreign body in the airway. So then you investigate the child. So these are the two scenarios. There are actually the foreign body in the tracheobronchial tree in the pediatric airway is always on increase now because of these four reasons, that the children are losing independence, increasing independence of children, and the parents are actually become very busy and they are unable to supervise the children, or there is increasing curiosity and increasing activity. So because of these four reasons, the foreign bodies are an increase. See, when you look at these four causes, why there is delayed diagnosis. So whenever the child has a foreign aspirates a foreign body, and the time from the aspiration to the presentation to the doctor, there is always delay because the parent will feel that it may be a simple cough and neglects, or a clinician thinks that it is a simple lower respiratory tract infection and treat them without any taking history or without any lack of suspicion. And lack of suspicion, and it is always misdiagnosed as asthma, lower respiratory tract infection or tuberculosis. So in this kind of scenario, the child, in spite of going to a doctor, they get delayed because of these reasons. So whenever is a history of choking episode, so we need to investigate the child. So if you look at the anatomy of the tracheobronchial tree, we know that the theoretically right main bronchus and left main bronchus are actually not in the same angulation, but right one is in continuity with the trachea and left one is more angulated. That means to say that the foreign body is more common on the right side, theoretically speaking. But when it comes to the reality, below 2 years, you can see this is the child is 16 months. You can see hardly there is any difference of angulation between right and the left. So theoretically, some of the books mention that the angulation is almost equal on both the sides below 2 years, theoretically. But sometimes we do see angulation, but sometimes you don't see. So that is not whichever side is the foreign body is there, we need to remove them. But for theory purpose, yes, right side is more common than the left side. So when you look at the how the patient presents with the foreign body, if it is there in the tracheobronchial trach. So number one is the cough. Cough is the single most important symptom in the tracheobronchial. In the absence of cough, we should always think 3 to 4 times that if there is a foreign body or no. First predominant symptom is the cough. Next is the breathlessness because of the partial obstruction of the airway. Suppose if the foreign body is in the, depending on the site or location of the foreign body, breathlessness will be more or less. If the foreign body is in the trachea, breathlessness will obviously be more. If the foreign body is in the subglottis and it is causing more obstruction, child may not reach the hospital. Most of the times, these are the kind of children which actually we lose them before they reach the hospital. The subglottic ones or the tracheal ones, bigger foreign bodies. And then if the child comes out of that, then they'll have wheeze, which is predominantly unilateral. See, clinically, if the foreign body, if the patient has some kind of infection, wheeze will be both the sides. But if it is restricted to one side, we need to understand that there is a likelihood of a foreign body on one side. Then they may present with pneumonia, they can present with surgical emphysema, and they can present as an emergency if the patient has trachea foreign body with the cyanosis. And child may get collapse and reduced breath sounds, of course. So this is the varied presentation is there. So by and large, the most important symptom which we need to keep in our mind is the cough, reduced breath sounds, unilateral wheeze. So these are the three things that we see, and we ask for breathlessness. So this is the presentation. You can see this child so sick like this with the foreign body in the subglottis. You can see gasping for breath here. And you can see this child there, how the child is breathing. So presentation, and you can see this child who has a bilateral foreign body. You can see the child struggling for breath here. The saturations were very low. The presentation can be like this, or child may have a unilateral foreign body and never have any problem except for mild breathlessness and cough. So the presentation varies. You see this patient who has a tracheal foreign body who has come at night. You can see the breathing, disordered breathing. You can see how the respiratory muscles, accessory respiratory muscles are acting with the saturation of almost below 50. So the presentation varies depending upon the size of the foreign body. And you see the same patient after removal of the foreign body, 100%. Before removal, it was 40%. You can see the presentation depending on the size and site of the foreign body. And you can see this child who has a foreign body in the trachea. Almost you can see child is gasping for breath and unable to tolerate any sort of mask, see this kind of presentation. So whenever you suspect a tracheobronchial foreign body, the most important thing is to take the thorough history. So you elicit the history of choking episode. If there is history of choking episode, then it leaves no doubt. Then we examine the child. See, as we ENT surgeons, I think we use a stethoscope a very less number of times. And I think this is the only time I use in my practice when I auscultate a child for a reduced breath sounds. And chest X-ray is very important, and most of the times we see the obstructive emphysema because of the foreign body obstructing the airway partially. We see the obstructive emphysema, and CT scan is done if required. Most of the times we don't do CT scan because the respiratory movements will interfere with the finding. Let us see the commonly done the X-ray findings. The X-ray findings vary from a normal X-ray. A normal X-ray will not rule out a foreign body. We all know that vegetative foreign bodies are not actually radio opaque, and that we will not be able to see the foreign body as such in the X-ray. So what we see is the whatever the foreign body obstruct the airway and causes some changes in the lungs. So for the changes to happen, it takes minimum of some time to happen. And then the most important thing, the most commonly seen is the emphysema. The next is the collapse of the lung, or it may be pneumotic changes are there. Sometimes you are lucky, the foreign body is radio opaque, you may see the foreign body as such. And sometimes there are changing signs because the foreign body, sometimes it is on the left side and then goes on to the right side and it keeps changing. So now let us see the actual findings. You see the first X-ray, you can see this is the emphysematous change. When you compare the right and left, you see this lung is more ventilated because the air getting trapped and it is not able to go out. That is why we see emphysema. Then next is the collapse. Whenever the foreign body completely obstruct the bronchus, there will be collapse of the lower part. So like this, you can see this is a collapse. And this is a radio opaque foreign body. You can see the radio opaque foreign body. And sometimes you see pneumonia-like changes. So it all depends on the size, the site of the foreign body. So the next is see, these are the bigger foreign bodies which are radio opaque. Actually, you can see. And most of the times what we see is the vegetative foreign bodies that we come across, and they produce emphysema. And there is one more entity that we need to remember is the bilateral foreign body. So bilateral foreign body, when we get, it's very rare, and it is the dire emergency. See, because when the patient has a foreign body on the right side, then we know that we compare with the opposite side, the X-ray as well as the auscultation. But when the foreign body is there on both the sides, so then it will be difficult for us to compare because both the sides there is a reduced air entry. Like same wise, if the patient has a bilateral, if any patient has a bilateral facial nerve paralysis, it is difficult to identify the facial paralysis because if one side is there, there is the deviation of the angle of the mouth to the normal side. If both the sides of the face is paralyzed due to various reasons are there about the bilateral facial paralysis, it is difficult because patient will not be able to laugh or smile. So in the same way, bilateral foreign body with a bilateral emphysema, X-ray is, so you can see this, both the sides emphysema is there. This is the child had a bilateral foreign body, difficult to diagnose unless we need to have a high suspicion. So when we diagnose a foreign body and we have to manage them, there is no medical management as such. So because we have to preoperatively prepare the patient. So most important thing is we need to check all our tools, the instruments. Then we must have an experienced anesthetist who is to handle such situations, pediatric patients in emergency. And we must have a theater staff who are well versed with the center and what procedure is going to happen. They would have known beforehand. And we need to preoperatively counsel the parents, very important, because earlier days we used to tell maybe 30-40 years back when lot of instruments are not very well developed and the anesthesia was not well developed. That time people used to say that the child may die on the table. The on-table death consent was in the vogue that time. But today, with the kind of patients that we get and the kind of instruments that we have and the anesthesia techniques that they have improved, so on-table death is the consent is not done. But we say that we are dealing with a child who is in actually emergency, and there is some risk is there. So we will not be able to tell what the kind of risk is that, but we'll always say it is not a routine surgery that is done, and it is always a risky one, but not to the tune of, not to the extent of on-table death. We do warn them that is a serious condition is there, and we always allow the anesthetist also to explain the children, parents that what exactly we are going to do and what are the outcomes. And we must always remember that this quote by one of the bronchoscopists that if you prepare 2 hours to do a bronchoscopy in a child, it takes only 2 minutes to remove the foreign body. On the contrary, if you take 2 minutes only to prepare your patient and the theater, it will take 2 hours to remove the foreign body, especially keeping the child on table and struggling for this instrument, that instrument is really not done. And it's always better you prepare yourself better and then go about. So then I just want to elaborate many times most of the juniors colleagues or the postgraduate are confused as to ventilating bronchoscopes are the only ones which can save the patient's life, and conventional instruments don't have much importance in that. It's a wrong notion that both the instruments have got their own merits and demerits, and I just want to stress upon the instruments part than the technique actually. Today's lecture that when we talk about instruments, we have two kinds of instruments. Number one is the conventional indigenous instruments, and we have ventilating bronchoscopes. So now let's see, start with the conventional instruments. See, we all must have seen this in our departments, the medical colleges, in the rack, old instruments who are actually not well used today, because this is the Negus type of instrument that's called as proximal illumination type of Negus instruments. The next is the Jackson bronchoscope. The difference between Jackson and this one is the one is the distal illumination, other one is the proximal illumination. So this is the actually the older versions where the light actually was like this, and this was connected to the source of battery actually, not a light source. They used to connect to the battery source so that the light will get illuminated at the tip, and this used to give fairly a good amount of light at the tip. But thanks to the today's technology that we have a very good powerful light sources. To start with, we had halogen light, and then today we have xenon, and we have also LED light, and which gives a very good powerful illumination to the tip of the bronchoscope. So now you can see the latest ones or conventional ones or this type of bronchoscopes available in the market. They are actually have a light carrier like this, which will be incorporated into the lumen of the bronchoscope. Then this will be connected to the fiber optic cable. You can use any light of your choice, and the illumination is better than the older ones. So this is the conventional one, which have actually vents for the ventilation. Yeah, little modernized conventional things are these ones. The earlier one, what I have shown, the difference is the light carrier was inside the lumen of the bronchoscope. The disadvantage of that was this one will occupy 1 millimeter of your space in the lumen. So that means when you take a 3.5 mm bronchoscope, you will have only 2.5 mm space inside to actually manipulate. But when it comes to this bronchoscope, the instrument maker has intelligently put the light cable outside all the time, and the distal part it goes inside. So this makes your life easy, that 1 millimeter of space is saved in the lumen so that you can manipulate better actually. So this is one way of there's an improvement. Then these are the conventional instruments that we spoken about. So now let's see the ventilating bronchoscope. When it comes to ventilating bronchoscope, the most commonly used are the stores, and that you cannot match the stores ventilating bronchoscope with any other thing, and is a gold standard. You can see almost all the sizes are available with them, from starting from 2.5 mm to 7 millimeter, and they also have a lot of accessories like this, and where you can use as and when it requires. See, this is how you assemble a bronchoscope. We know that this is a ventilating bronchoscope. See, the simple meaning of ventilating bronchoscope is that your bronchoscope is going to act like an endotracheal tube in the tracheobronchial tree. That's all. So that means you say that you keep this lumen in the trachea or bronchi, and the child will be getting ventilated through this port by the anesthetist, the white one, what we see, and he will be ventilating the child comfortably. And you will take care that the whatever the air is getting will not leak out. So you use a seal of that. So this is the ventilating bronchoscope. So the difference between ventilating bronchoscope and conventional thing is that in the conventional thing, we cannot able to ventilate the child continuously, because we will be giving the jet ventilation. You give high volume of oxygen as a puffs we give. Whereas in ventilating bronchoscope, you can continue the procedure for any length of time, maybe half an hour, 45 minutes. But in conventional thing, you cannot prolong the procedure for more than a certain stipulated time, like maybe 2-3 minutes, because you cannot ventilate the child like how you are able to ventilate through the ventilating bronchoscope. This is the single most important thing that you need to understand. What is the difference between the conventional and ventilating bronchoscope? So these are the various accessories that comes with the storage bronchoscope, and this is the adapter. See, this will be closed with a glass like this, so that whatever the ventilation is happening, the air will not get leaked. This is very important when you want to do bronchoscopy for a long time. You can use this ventilating bronchoscope. They are very safe actually. And apart from ventilating bronchoscope, stores will have, or any company that gives you an optical forceps. So this is optical forceps. The very advantage of optical forceps is that you introduce the optical forceps will have an incorporated telescope in that, where you can actually see the foreign body from a very near this one. Then you can catch the foreign body with minimal damage to the surrounding mucosa. So that's the advantage. So there are advantages of optical forceps. Likewise, any instrument will have disadvantage. So optical forceps cannot be used in a small children below 1 year because of its size. So having optical forceps is not you can do so many things. But I think the presentation in the full screen, if I am correct. Somebody asked a question. Harsha, is it okay? Presentation? Harsha?
Yes, sir.
Hello?
Yes, sir.
Presentation in the half screen mode or full screen?
Then only, sir. You can go ahead, sir.
Full screen, full
Yeah,
screen.
somebody is, yeah.
No, no, sir. You don't get distracted, sir. We'll inform you if any problem.
Yeah, this is the next. This is the next generation bronchoscope you can see. See, in the recent times, we all know that the laryngoscope has come with an incorporated telescope, which is angled upwards so that it will not impede your vision when you want to see through the lumen. In the same kind, Texas people have recently designed a bronchoscope which has an integrated telescope into that, which actually will not come in your way of instrumentation or visualization. So if you have this in your practice, and it becomes even more easy for you to handle the patients. Actually, we have very large working space, and I think they are little expensive if I am not wrong, and they are very good if you can get them. And I had always been thinking, what next can be done if there is a foreign body, instead of removing. See, we all know that the foreign body requires removal, but when you can't remove the foreign body, then what can be done? I was thinking at the back of my mind. So now I was thinking actually 10 years back that some instrument who can design like a debrider blade where you can keep into the trachea and then cut the foreign body and suck it. So now there are endobronchial shaver blades which have come into the market, which are actually used by thoracic surgeons to debulk some of the tumors. Like this, these are the endotracheal blades that they have along with the shaver. We all know debrider we are using. Same kind of the blades are there, long ones. Can they be used to cut the foreign body without damage to the tracheobronchial foreign body? I don't know. People, we must practice these things on cadaver and come to some conclusions. And this is only theoretical. Just I was going through the literature and I got this that these endobronchial shaver blades are actually used to debulk some of the tumors. Maybe in the days to come, we may use them in the removal of the foreign bodies after many trials in the cadaveric. So this is the instrument. See, this is one of the, when I was searching the literature, I got this article. This is one of the pediatric surgeon who's actually practicing in Mumbai has designed a forceps of this kind, which has many things in this. It has a ventilating bronchoscope, it has a forceps, and it has a USB port, it has a camera at the tip, and it has got everything in one, all in one, where you can pass this into the tracheobronchial tree and remove the foreign body with ease. So this is actually designed by one of the pediatric surgeon in the Mumbai. The article is there. You can always get through that. And he has designed and he has done about 100 patients. And the instruments is actually 5-in-1 instrument, which is a genius merger of a telescope, LED light source, ventilating bronchoscope, sheath, and bronchoscopic foreign body removal forceps, all in one with one forceps. It is actually described for the first time in the medical literature. The next is the when you want to have a ventilating bronchoscope, when you can't afford to buy storage ones, you can actually go for this indigenous make, and you can see the Optimed is the one which actually. But the only difficulty that I found is that this doesn't have a handle to hold. That is the only disadvantage that I actually come across. And these are the various types of foreign body forceps that we have at our disposal to use, and various types of suction tubes and accessories, and to hold the foreign bodies actually. And the next what you want is the cheaper ones. When you want an imitation one or a cheaper one, we look at the Chinese products. And I can tell you the Chinese product is not less than our stores one. And these are the Hawk make telescopic ventilating bronchoscopes are very good. And we can't compare what with the stores, but you know, we must remember that what you pay is what you get. And these are not very expensive to have. So very good, I can tell you, an alternative to the ventilating bronchoscopes are the Hawk ones. They have all the system, rod length systems they have, and then they have telescopes, everything they have. So these are the various instruments that we have in our market. It is the surgeon who has to select his instruments to do the procedure. So ultimately, whether you use ventilating bronchoscope or conventional thing, you have to remove the foreign body. That's it. So when you compare the ventilating bronchoscope with the conventional this one, so let us see. The telescopic bronchoscopy is, you can see the foreign body clearly, and you can use what kind of forceps that you have to use to remove the foreign body. So once you remove the foreign body, you can always look for a residual or a leftover foreign body or a second foreign body. So it's always better you use a telescope. The single most disadvantage of the optical forceps is, I cannot say that is a disadvantage, is a limitation is you cannot use this in below 12 months of age group. You can use 14-15 months with difficulty, and it takes more time than the conventional forceps, because optical forceps you have to assemble, then you need to have second light source, and you need to have a second assistant. So in an emergency, you cannot have so many luxuries. In an elective thing, okay, if the foreign body is there on one side for a very long time, the child doesn't have much respiratory distress, you can do all these exercises. But when the patient has severe respiratory distress, the falling saturations, I think it's better to use conventional instruments and let the foreign body out than you struggling to remove the foreign with the telescope. So that's the only disadvantage of the telescope. So we must understand this, what is forceps space. So in most of the times in postgraduate exam, we will be asking you what exactly is the forceps space when you remove a foreign body. So the space that is there in between the foreign body and the bronchial wall is the forceps space. If there is no space between the, see, the space will increase when you ventilate the child. See, when you ask your anesthetist to ventilate the child, as the ventilation occurs, the bronchial wall will inflate. It will become more. So that time you will get the space to catch the foreign body. So that is the space. If the space is not there, then it will be difficult for you to actually retrieve the foreign body. So when we want to remove a foreign body, there are 5 concerns are there. Number 1 is you need to ventilate the child properly. That means the saturation should not fall. The next is the distance, because the distance between your eye and the foreign body is so much so that your vision should be clear. That means if you are using spectacles and if you are above 45, you need to check your vision very often, so that you should have a very good vision. Otherwise, you will be struggling to remove the foreign body. Number 3 is illumination. What kind of a light that you are using and what kind of a digital source that you are using. So most of the times, if it is white light, it is better than the yellow light of halogen. The instrumentation. If you have very good fine instruments, that will be easy for you to. So these are the 5 things that you should keep in your mind. And the conventional bronchoscope, as I said, they are less expensive and easy to get. And the only thing is, the disadvantage is we need to be very quick. We can't take more time in a conventional thing like ventilating bronchoscope, because the anesthetist here will be using a jet ventilation, which cannot take more time. So, and one more disadvantage is you cannot use optical forceps with the conventional. You can use an endoscope to visualize the foreign body, but you cannot put ventilating, we cannot use optical forceps because the size of the forceps is bigger and it cannot negotiate through the conventional thing. And the most disadvantage thing is the monocular vision, because you are not using optical forceps, you cannot see on the screen. So it's you have to see with one eye. So these are the disadvantages. Now let's see how we remove it. See, the anesthetist is showing me the cards. I will introduce the bronchoscope into the trachea. See how the anesthetist is ventilating with the jet ventilation, and I remove the foreign body. So this is actually unedited video. I have removed the foreign body in less than 1 minute time. So if you can do this, then it's okay. You can use the conventional instruments. So you need to be very quick. On the contrary, these are the instrument that you need to have. This is the jet ventilating Sanders type of this one is available. It was available in the market. Nowadays, see this on my right hand side, you can see where we can have a control of oxygen, how much you are giving can control. So this thing is not actually indigenous. It is actually a German make. You can get in the market now. It is costing somewhere around 80 to 90,000 today. This one on my right hand side. And now you see how a ventilating bronchoscopy is done. See, the anesthetist, the surgeon has introduced the bronchoscope into the tracheobronchial tray, and now anesthetist actually is connecting his tubing to the tube and ventilating very nicely. And I thank Dr. Shivanand of Koti ENT Hospital for his generosity in extending. He has given me this video, and the surgeon is Dr. Anand Acharya, and so I have taken the video of Dr. Shivanand. Now you can see, you can use ventilating bronchoscope comfortably, no urgency. Child is being ventilated very nicely. Nobody is in a hurry to, and controlled ventilation, and the surgeon can remove the foreign body. See the difference between conventional and ventilating. You can see the movement of the chest. Yeah, see that? Comfortable. So this is the difference between ventilating bronchoscopy as well as the conventional. Now you see ventilating bronchoscopy that I have done. Anesthetist always show the cards. Then we enter into the tracheobronchial tree. Yeah, now you can see once I'm inside, see he is connected. He has connected the system to the ventilating one, and comfortably I am able to remove the foreign body without any stress on my side. I'm not using any telescope. I'm using the conventional forceps. You can see the foreign body is being removed from a child. You can see a bigger one, plastic one. So that is the difference. Now you see how we use the telescopic forceps. See this foreign body is in the coronal plane. It is in the subject horizontal plane. So this is not in the line of actually larynx. So we need to actually do a version, or we need to turn the foreign body into the sagittal plane like that. Now this foreign body, see, you must remember that you should be able to catch more than 50% of the foreign body. That is that you must catch beyond the equator of the foreign body. That means you should catch more than 50%. Then only you can get the foreign body in a full piece. See, if you catch only 25% of the foreign body, it gets broke, and then you remove a piece of it. So see, that is how you must use the telescopic forceps. The telescopic forceps tip is very thick, so it will not be useful in very small children. So now once you remove the foreign body, you always check again with the telescope for a second one if it is there. Or we call this as a check bronchoscopy. See, there is no residual foreign body in the on the right side. You can see the, sometimes you will get confused interbronchial septum as a foreign body, because as you go near to it appears white. You remember that the left side foreign bodies are difficult to retrieve because the left main bronchus is longer than the right one, and it is narrower than the right. So left side foreign bodies are difficult because of the reason. See, now you see there is a peanut in the right main bronchus, and I am trying to remove actually with the telescopic forceps. See, we need to assemble the forceps like this. Then we need to attach a camera to it, have a second light source. See, I am able to catch the foreign body, and once you come to the level of the glottis, we need to do some kind of a version. We need to actually tilt the forceps towards posteriorly, because when you remove the foreign body, it will be towards the anterior part where there is no space or very less space because of the anterior commissure. But when you tilt the forceps posteriorly like this, see, like this, then the foreign body comes into the posterior part of the glottis where there is more space is there. So you can avoid shearing of the foreign body into two pieces. So you need to remember this, that you need to turn the foreign body posteriorly when you approach the glottis. So once you remove the foreign body with either telescopic forceps or or conventional thing, we need to always check the foreign body. See, again, you can see this a small piece of residual foreign body in the terminal bronchioles. It will be difficult for you to remove these tiny pieces with the forceps. They usually come out of coughing, but only thing is we need to make a note of it in the operative notes that they are left as very small, tiny pieces which are likely to come out on coughing. And we also need to explain the parents. And when it comes to visual parts, you must know that there are 3 or 4 components in the visual parts. Number one is the outer one, black one, and the 2 small whitish ones, and the middle part is the greeny one. You can see here 4 components are there. So all 4 you need to remove at once, because otherwise one foreign body will become 4 foreign bodies if you try to catch each one of them. So it is always better practice. You ask the parents to get a dummy foreign body. If the child has swallowed aspirated visual parts, always ask them to get another one which will be available from where they bought actually, so that you can actually plan what forceps can be used, and so it will be easy for you to practice also. So once the foreign body is removed, you have a check bronchoscopy also. So we all know that now when to do a bronchoscopy, but it is always a better practice to know when not to do bronchoscopy. So you can see when a patient is referred to you, child has a severe breathlessness but no cough. Child has severe breathlessness with high fever. Breathlessness has actually started after an attack of fever or cold. So in the absence of aspiration in these children, an acute condition, always recognize medical conditions which mimic foreign body and avoid doing bronchoscopy. You see this tricky situation, and you see this child who was actually referred to me for a bronchoscopy. So you avoid doing bronchoscopy in such children. The procedure, just I want to explain, always done under general anesthesia with a jet or ventilating bronchoscope. So now, see, the first step is to pass the bronchoscope. Always ask your anesthetist to show the larynx so that you can pass the bronch. You can see the light here. It will be easy for you to introduce the bronchoscope. So once you introduce, see, once you introduce the bronchoscope, when you want to see on the right side, turn the head towards the left. When you want to see the left one, you turn the head towards the right. That is how you should be able to align your trachea and bronchi into one line so that you can remove the foreign body easily. So this is a 12 years old boy who had actually visual parts in the, you can see that the right main left side, it has got migrated while removing the right side. So you turn your head, the patient's head, to the other side when you want to see. You see, foreign body is being removed with a conventional instrument. The foreign body was in the trachea actually. You can see the concentration that you must have. You can see my eyes when you remove the foreign body without blinking. So that is the concentration that you must have when you remove the foreign body. See, when the patient has a foreign body like this in the subglottic region, where you can neither intubate nor ventilate, then if you actually pass your bronchoscope into it, it will go. If you are unable to actually ventilate the child, it is always better to push that foreign body onto one side before you remove. See, now In this situation where the child is severely distressed and the anesthetist is showing the cards and I am removing the foreign body without any sheath that is kept into the tracheobronchial part. So it is always better not to do this way actually unless you are experienced. See, it is always risky to use forceps alone without the sheath in the tracheobronchial tree. But if you are very well experienced, anesthetist is there and you are also experienced, you can remove the foreign body very quickly like this, then it's okay. Otherwise, it's always better practice to push this foreign body onto one side if the child is unable to get ventilated and remove it leisurely. And I want to show another plastic one, which was a H letter, which was aspirated by a child. It was sitting in the subglottis. You can see again, I have tried this without bronchoscope into the place. I was unable to retrieve this foreign body. See, it has gone into the trachea. Again, I tried. See, I was able to catch it, but I was unable to bring it through the glottis. As you see here, it is getting stuck. See, I was unable to do. So then I broke this into two pieces and I removed. And again, foreign body is in the coronal plane. So if you can remove this foreign body, the same plane is not done. You need to rotate the foreign body. You can see my fingers. Once I catch the foreign body, I rotate the foreign body into a sagittal plane and it is easily removed. Now you can see how I rotate like that. See, rotate like that and then bring the foreign body to the mouth of the forceps and then retrieve it. So this is how you must be able to remove the foreign body. Again, a variety of foreign bodies you get. Use a nail in the 3 months child. Very small child. I used a very small telescope, bronchoscope, 3 mm, and removed the foreign body. Sometimes you see anomaly like this. See, this actually something called as a tracheal bronchus. That means once you remove the foreign body, I will show you the rare foreign anomaly I found. That is, you can see this is a trach. Actually, this is the carina, and you can see this is the left main bronchus. This is the right main bronchus. There is a third bronchus present here. You can see this. Can you see this third one? So this is actually called as tracheal bronchus or a pig bronchus. Sometimes we get confused this as the carina and ignore the left side. So you can see 3 openings at one place. So this is the tracheal bronchus, a rare anomaly that we come across. So so nowadays with the introduction of nasal endoscopes in our field, it has opened new horizons. So what I do is I use endoscopes very frequently. There is a nasal endoscope as well as the bronchoscopic long one to remove the foreign body. Before removal, during removal, or after removal. Just I will share my experience. So any patient who comes with foreign body in the tracheobronchial tree, I just ask my anesthetist to show the card and put nasal endoscope quickly in the trachea to note the position of the foreign body like this and how it is presented and what is the number. Then I select what kind of instrument that we need to remove and then I remove the foreign body quickly. So then see how this is out. So anesthetist will show me the cards and I put the 4 mm nasal telescope through the larynx and examine the tracheobronchial tree on the monitor. See, like this. Now you see there is a bunch of staplers on the left side. I note its presentation. and I come back and ask the anesthetist to ventilate. And now I pass the bronchoscope and remove the foreign body. So it's, you can plan your forceps and you can plan your removal. It's the best way to do that. So you can see again this child who had a history of distress, and when I passed the telescope, nasal telescope, I could not negotiate this beyond the midpoint of trachea, as if something was pushing from behind. Trachea was completely like a small slit here. I could not pass 4 mm nasal telescope, and post-operatively this patient has to be kept on ventilator because we were unable to ventilate the child. So to our surprise, it was not a foreign body, but actually it was a mediastinal tumor, which was actually pushing the trachea from posterior to anterior. You can see there was hardly any space here, which was actually mimicking a foreign body. So it's always better if you can get a scan done also preoperatively. If the patient can afford, we can diagnose such rare things. So once you remove the foreign body, you always keep examining the child for a second foreign body. You see this patient, I actually passed the telescope. There was a foreign body on the, you can see the foreign body in the right main bronchus. I removed the foreign body. And you can see on the left hand side, left main bronchus, there was a mucus plug continuously running from trachea towards the left main bronchus. I ignored that first because I see a foreign body here. So once I remove this foreign body, then saturations were not improving. So then I again passed a telescope bronchoscope onto left side. Then to my surprise, I see a second foreign body of a different kind. So on the right side, I see a peanut. On the left side, there was a dal seed on the left lower lobe. You can see a dal seed on the left lower lobe is a different foreign body in the same patient. So it's always better practice for you to check the tracheobronchial tree once you are done with the removal of the foreign body, to check if there is any second one. To your surprise, you may find one in some situations. So we should not leave that. So once you remove the foreign body, again you pass a 4 mm nasal telescope, examine all the places, and if there is any small pieces of foreign body, make a note, and if the some part of the foreign body could not be removed, you be honest to the patient, tell the parents that the child may require a second sitting to remove a foreign body. So never keep the thing secret to the parents. So there are some situations where we require to do a tracheostomy to remove a foreign body. See, in this scenario, I can see there's a very big beetle nut which was stuck actually in the, we were unable to remove it in the midnight. So there's a very big beetle nut. I had to do a tracheostomy in the midnight and then remove a foreign body like this. So there's a really limited role of managing this one. Foreign bodies which cannot come out through the glottis has to come out through the tracheostoma. And the tracheostomy, we can close the next day also, no problem. So this was the patient who had a big chunk of beetle nut. It was in the actually trachea. So there are instances where we have failed to remove the foreign bodies, and we have to resort to thoracotomy. And see, actually, this is a very funny story. This child had a foreign body in the subglottis, and some other people have tried to actually remove this foreign body, and they have successfully pushed down into the deeper planes like this, and the child was referred to me with the tracheostoma like this. I removed the tracheostomy because it was no longer required, and I tried to remove this foreign body. Here, this is the one, same kind of a dummy one. I could not do that. So I referred this patient to a place where many ENT surgeons are there. The place is none other than Koti ENT Hospital. And this patient was tried by our senior most surgeons on 3 or 5 occasions for 1 month the patient was in the hospital. They could not remove these, and finally it was removed at thoracotomy by a cardiothoracic surgeon. And again, one more failed case like this, we are referred to thoracotomy, and this was removed at Care Hospital. And these photos are Dr. Hemant, courtesy by him. At thoracotomy, they removed the foreign body. So there is a role of thoracotomy or bronchotomy to remove the foreign body. Post-operatively, the most of the thing is once you remove the foreign body, child will improve. And it is a wrong notion that we must have a pediatric ICU to remove a foreign body. No, it's wrong notion that if you remove a foreign body in a dying child, patient will recover. But if you do a bronchoscopy for a wrong indication like a medical condition, a normal child will also require an ICU setup also. So we give antibiotic and give some steroids post-operatively and oxygen. And this is my experience. Maybe some more cases because after this presentation also we need cases. This is my personal experience of managing variety of foreign bodies over a period of 22 years. This was earlier I used to collect all the foreign bodies that I removed in a this bottle. Once we shifted to the new hospital, all these were actually missed. I don't have any collection now except this photograph with me now. And these are the various kits that I have handled in the past with the foreign bodies. And adults, I removed foreign bodies in 5 to 10 patients. And this is a needle, hypodermic needle, which was actually piercing the mediastinum like this that I removed. And recently, I removed a patient who was interesting case, actually mentally retarded adult who actually aspirated this. This needle actually is used to inject the animals. Actually, we went to a veterinary hospital wherein the injection was given to the animals, and then this new needle he has taken to actually clean his teeth in between the teeth like a toothpick, and suddenly he got aspirated into his left side bronchus, and then this is a telescope, actually 4 mm nasal telescope I'm using in an adult. You can see my telescope is reaching up to carina, but I am unable to see beyond that. So actually this patient, I bring the foreign body into the subglottis. As you see here, you can see the needle. You can see the needle here. Needle, glimpse of needle. I could not remove without the bronchoscope. Again, I inserted the bronchoscope and I removed the needle from this adult. So adult also foreign bodies are common. Not very common, but we do come across. See, now the very aim of this presentation is to motivate our young ENT surgeons and postgraduates to take up this task of managing such tracheobronchial foreign bodies. But in your postgraduate training, you will hardly get hands-on experience for a bronchoscope, because whenever the tracheal or bronchial foreign body is there, all PGs will be watching and a senior most person will be handling the situation. And a junior most person will never get an opportunity to learn. So this is a fact. But how we should learn the art of bronchoscopy? So now with that idea, we conducted a hands-on course in 2010 in our place. So we need to learn all the basic skills of handling. See, how you learn a surgery is you learn the anatomy, you learn the technique of handling or using the instruments, and then you do the surgery. So now if you want to learn all at once in a struggling emergency patients, it will be difficult for anybody or any senior to teach you such basic skills. So I always strongly recommend all the young postgraduates to follow this sheep lung mannequin. So what you do is you buy a sheep lung like this on a Sunday morning. If you pay 150 rupees, you will get these 2 lungs along with the trachea, and the larynx will be actually attached to the head. You ask them to cut this larynx and give you, and you suture this larynx to the trachea like this and mount this specimen on a plastic board or a cardboard like this, and Now you pass the bronchoscope through this larynx into the trachea and see the bronchus. And then you put nuts and from foreign bodies and remove. See, now you see this animal model that we designed. So now you pass the telescope in the trachea of a sheep, and now you note that there is hardly the angulation of right and left main bronchus is more than in adult, more than in a human. You can see here. See, this is the left and this is the right. Angulation is more, and there is the only difference. So you pass the bronchoscope and then put various types of foreign bodies into it and keep on practicing. So you learn this. You do by doing this. What you learn is the psychomotor skills and how you pass the bronchoscope and how you actually pass the telescope. All the teething problems you learn here. It is like doing a sheep head dissection in the cadaveric endoscopic sinus surgery, or by doing a temporal bone dissection to learn ear surgery. So then again I designed a small rubber tube mannequin like this. See, this is a box prepared by a carpenter, and you put a Mellicot's catheter into it like this, and you pass the bronchoscope into this tube and mimicking the trachea and the bronchus and keep on removing the foreign body. See, now is the telescope being used and put foreign bodies in the tube and keep on removing them, so that you'll know what is forceps space here, what is the depth perception. Keep on doing this. So this mannequin training actually we did in our state conference, and most of the people got benefited out of this. If anybody wants to do this kind of program, we are ready to teach them in any conference. If you give me 3 to 4 hours, we can train all the attendees with these 2 mannequins. We conducted this program in many places like Bhubaneswar. We did hands-on training. So why we do mannequin practice in bronchoscopy is to learn hand and eye coordination, learn psychomotor skills, learn depth perception, learn the art of instruments. All these things you learn here, and your removal of foreign body will be easier, I'll tell you, than you taking your first steps in learning the skills on the patient. So it will be difficult for anyone to teach you in the OR in a struggling patient and to give it to a junior colleague to handle such emergency scenario. If you can learn all these things and show to a senior that you know all these things, definitely anybody will give you to do a case. So that is the secret of learning. So now 2 points that we need to ponder is whenever you have a patient who has a choking episode while eating, persistent cough, you resort to tracheobronchial foreign body is there. You always do a bronchoscopy and remove the foreign body. So now we need to educate the parents also in the social media that never give nuts to the child below they develop 8 years because the molars are not there. So that is the thing. So to conclude my talk of today, there is no substitute for clinical suspicion. So managing tracheobronchial foreign bodies is always a teamwork of, it is a pediatrician who actually have confidence in us. I thank all my pediatricians around where I practice for having confidence in me and giving me patients to manage, and I thank them. Pediatricians are the one who actually suspects, and I respect our anesthetist who comes on time and saves many patients, and then an experienced anesthetist, and of course ENT surgeon and theatre staff are the key persons. And I request all our ENT surgeons that this art of removing bronchoscopy is our domain. Please don't pass on this art of removal of bronchoscopy to thoracic surgeons or pediatric surgeons or pulmonologists. This is our domain. So we must retain this. So I request everyone to actually do more and more cases and save children. It is the parents' education also is very important. And pediatric bronchoscopy is much safer than what we are thinking that 30 years back. It's very safe. We don't lose any child on table. The So it requires more training programs. That's all. So now, whenever we are, when you take up a patient, we look at the success. But when you want to see success, you will face problems, you will see complications, and you will failures. Then only you can appreciate the sweetness of success. If you get success in the beginning, then it will be not be so tasty like how all these three you must taste before you actually see success. So this is how the races, we all know that are not won by accelerating on the top gear. It is the change gears the right time will take you to the higher heights. Changing the one gear at once. Thank you very much for your kind attention. I just want to share a very rare foreign body that I come across in my practice. It is not the tracheobronchial foreign body, and it is you see, this is a fisherman woman who was in the midnight. She went to a pond to collect the fishes, and she took some water to drink. She took the water and she actually drank that water, and then in that there was a live fish was there, so which went into her throat, and then she was unable to breathe. So somebody beside her came and they manipulated somehow, and they could not remove the fish, but they pushed into the nose so that she survives and she doesn't have respiratory distress. So then the next day morning she came to me. Then I see a tail of fish hanging behind the soft palate. Now, under local anesthesia, I start examining the nasopharynx. Now, you can see this fish got molded, fractured itself, and the head was in the right middle meatus. The body got fractured, and the 75% of the body was in the nose and nasopharynx. And by holding the tail, I manipulated the fish to come out of her mouth like this, which was very long. So this I operated about 12-13 years back, and still I remember this was a very rare foreign body that I removed in my lifetime. Thank you very much for your kind attention, and I am sorry if I have taken more time, and I thank the organizers for giving me this opportunity. And thank you all audience. I can to the extent possible. Thank you.
Thank you, sir. Thank you, Jay. Excellent presentation. I mean, the sheep lung mannequin was the best thing. Everybody it was fully glued to the last 1.5 hours. Fantastic, sir. A great thing. We in Telangana state would like to do the same workshop with you in very short time, sir. Thank you very much, sir. Thank you. Thanks for an excellent presentation.
Thank you, Jayaprakash, sir. Excellent presentation, sir. You have not taken time, sir. You have taken your time. Thank you so much for giving your valuable, precious time to us, sir. Thank you, all the audience, sir.
Sir, questions, sir? More questions?
And yeah, that was excellent presentation, Dr. Jayaprakash. It was the last foreign body that you were showing that I mentioned.
Yes.
When I invited you for when I remembered that, I called you for the lecture. That was beautiful. And as you rightly pointed out, the practice, cadaveric practice and maneuvering the instrument and then passing a focus to that and removing, that must be practiced beforehand, before people get onto live patients. That is important.
I just want to tell the postgraduates who are present here that, see, if you can show your teacher that you know the art of handling the instruments, no teacher will deny you. They will give you a chance to operate. See, it is always difficult for you to learn all these basic things on a live patient. See, handling of instruments is very important. Maneuver in ENT. You learn all those skills on cadavers and come to the theater and you will do things very easily. Please attend cadaveric courses, do these mannequin trainings, and there are a lot of mannequins available these days. And the mannequins, what I showed you, was very cheaper ones. I am ready to teach anyone. If you can conduct, we conducted in our state conference. We had one day live update also in Bhubaneswar. Many people we have trained, and we don't mind training many people, but no child should die of a foreign body bronchus, even without reaching to the hospital. Even if they reach hospital, they don't know how to manage in many places. So every ENT surgeon should be able to remove the foreign body bronchus. That's the main motto of this presentation.
Thank you, sir.
Yeah.
Good morning, sir.
Good morning.
Sir, I'm Dr. Ramesh, sir. Can I ask you something, sir? Sir,
Please.
if any sharp foreign body is stuck in bronchial wall or tracheal wall,
Yeah.
stuck sharp, both the ends are sharp. Like, sir, just now you showed me like any sharp needles or something. So if you want to bend and remove, how we should bend and we should remove, sir? That is my one point. And the second point, while removing accidental damage to the tracheal wall or bronchial wall, inoperatively or post-operatively, if we find like some tracheal wall injury or bronchial wall injury is there, how we should manage?
See, the manipulation of a foreign body in the tracheobronchial, I cannot tell you in one word. It all depends on that scenario, the length of the foreign body, the kind of instruments that you have. This is always, you have to manipulate in the given situation. I cannot tell you how I manipulated in that patient. See, you have to take a stronger forceps, the stronger than the foreign body to bend it.
Okay.
Remember that. If your forceps is weaker than the foreign body, it will break.
Okay.
If it breaks, then it will become another foreign body.
Yes,
Your
sir.
forceps, what you use, should be stronger than the foreign body. That's number one.
Yes.
And the sharper objects always has to be pulled into the lumen as long as possible.
Okay.
Number three, if there is a small rent or small damage to the tracheal wall, will not cause any problem. If it is a bigger one, it may cause some kind of a pneumothorax or something, which warrants tracheal chest tube has to be kept. You have to see only for a pneumothorax. That's all.
Okay, sir. Okay.
It
Thank
has never happened to my in my practice.
Yes, sir. Yes. Thank you, sir.
Thank you. Harsha,
Sir.
if there are no questions,
Yeah, you,
can we call it a day? Yeah.
yes, sir.
Thank
Thank
you.
you, sir.
Thank you so much, sir. Thank you,
Sir,
sir.
Thank you. Bye bye.
Thank you. Bye.
Thank you, JP. Thank you very much. That was very nice.
Thank you, sir.
Excellent, sir. Thank you.
Hi, JP.
Thank you. Hi.
Bye.
Bye, sir.
Harsha, you can